In part one of this recording on pain and inflammation, we addressed the opioid analgesics. In part two, we're going to talk about another really important group of drugs, the non-opioid analgesics, and we'll also talk about the treatment of inflammation. Again, very, very common drugs. We see them very often in our practices. So here we go with the non-opioid analgesics. The name tells you that they're not the same chemicals as the opioids that we saw in part one. The major players here are the NSAIDs. NSAID, of course, stands for non-steroidal anti-inflammatory drug. They're not steroids. They do have anti-inflammatory effects, and we'll see them cross over into both treating pain and inflammation. Then we'll talk about a specific drug called acetaminophen, and we'll explain why it's not an NSAID, but why it is still a very important medication. So first, the NSAIDs. And we're talking about them now for really their analgesic effects. They do have anti-inflammatory effects, and that's what the name says, anti-inflammatory drug. They also have antipyretic effects, which means to decrease fever. Pyresis means fire or heat. Pyromaniac lights fires. So when we think antipyretic, we're thinking of drugs that decrease fever. They have anticoagulant effects, and we'll briefly touch on that here. And this is where we see things like low-dose aspirin therapy being used to prevent heart attack and ischemic strokes. We'll focus on that aspect much more when we talk about the anticoagulant medications as part of cardiovascular pharmacology, but a very important effect. And finally, there is some fairly substantial evidence that these drugs may decrease certain forms of cancer. We know this is possibly true with the aspirin-like drugs that decrease the risk of colorectal polyps that could become cancerous. I left a question mark here because there's still a lot of information to be obtained on this, but it's pretty clear that NSAIDs, aspirin and possibly other NSAIDs, may help decrease the risk of certain cancers. So the word NSAID is not a good name. We really should call these NSAIDs because of their real versatility. The fact that they're able to treat 4, maybe even 5 major problems. And when you consider that heart disease, cancer are the 2 leading causes of death and illness in our society, this is a pretty remarkable thing. The point is, these are very important medications. They're very common, they're very affordable, several are available over the counter. We almost lose sight of. And there's several of these. As I said, some of them are available over the counter. Aspirin is more or less the grandfather of this group, or the prototype of this group. The discovery of aspirin, how aspirin works, led to the development of other NSAIDs like ibuprofen, which started out as a prescription drug and then made the jump to over-the-counter. Same thing with naproxen and also ketoprofen. And what happened, of course, is these drugs were available originally by prescription, not aspirin, the other 3. Aspirin has always been over the counter in this country, but the other 3 were available by prescription originally. And then, because of the safety profile, they were allowed to be offered available directly to the consumer. The prescription dose, of course, is usually much higher than the over-the-counter dose. For ibuprofen, typically an over-the-counter dose is only about 1/3 of the prescription dose. This brings up the problem, of course, with our patients, our clients, knowing that they used to take a much higher dose when they had a prescription form of the drug, and they'll take their over-the-counter medication at higher than recommended. That's not good. We should always encourage them against that if they're going to take these drugs over the counter, they should stick to the prescription or to the recommended dosage on the over-the-counter product. If they're not getting full benefit, it's time to get back to the physician. Maybe they do need a prescription, but to arbitrarily crank up the dosage of these over-the-counter medications is not a good thing. Other NSAIDs are available only by prescription. We see some of the more less common ones, rather, like Ketorolac, phenoprofen, which is, of course, an ibuprofen cousin. Ketorolac, very powerful. Ketorolac is often administered by injection parenterally at the end of a surgery to serve as a bridge between the anesthetic and the post-surgical recovery. Meclofenamate, very old but goodie. Piroxicam, again, been around for a long time. And a couple of others too. A key question often arises in our patients: are the over-the-counters the same as the prescription? So if we compare over-the-counter and prescription NSAIDs, are there therapeutic differences? Not really, if you give the same relative dose. I mentioned that usually the over-the-counter dose is lower, often remarkably lower, than the typical prescription dose. But if you give the same relative dose, you've leveled the playing field, they're pretty much the same drugs. Are there safety differences? Not really, again. This is related to dosage. And as I said, the whole point of making these drugs a lower dose when they're over the counter relates to the fact that we're trying to account for these safety differences by lowering the dose. At the same dose, they have the same relative safety profile in terms of both their safety and their side effects. So really no differences there. Are there cost differences? Absolutely. And we know that the over-the-counter products are often remarkably less expensive than the prescription products. But still, there's no real difference in the over-the-counter versus prescription other than related to a typical much lower dose than the over-the-counter product. Now we have to spend a few minutes talking about how NSAIDs do what they do. How does one chemical, one medication, cause so many different and important side effects? Pain, inflammation, fever, coagulation, and possibly even anti-cancer. And this was a real mystery. Aspirin had been around for probably over 100 years before we discovered exactly what it does and how it works. We know now that all the NSAIDs share a common mechanism. They all inhibit the synthesis of these compounds called prostaglandins. And prostaglandins are small lipid compounds that can be produced by virtually every cell in the body. And typically they're produced when a cell is injured. If a cell is traumatized in some way, physically, thermally, immunologically, it produces these small lipids which cause a lot of other physiological features. They increase sensitivity to pain. They raise body temperature and fever. They promote inflammation, or they serve as a messenger that promotes inflammation. They cause abnormal blood coagulation and possibly even produce certain type of abnormal cell growth. So, what do the NSAIDs do? They inhibit prostaglandin production by inhibiting an enzyme called the cyclooxygenase, which is a key step in prostaglandin. So this is how prostaglandins are made. A cell needs to make a prostaglandin for whatever reason. It takes a membrane, a phospholipid out of its cell membrane, transforms it into this first product called arachidonic acid, which is a precursor. It's 20 carbons in length. The key step is arachidonic acid is transformed by this enzyme called the cyclooxygenase into the first prostaglandin, prostaglandin G2, which is then transformed into the next prostaglandin, prostaglandin H2, and from there the cell can make whatever prostaglandin it wants or it needs. And as you can see on the bottom row here, it's a family of compounds. Not all prostaglandins are the same, and they have different physiological effects. The PGIs, the PGEs tend to be vasoactive. Some of them cause constriction, some of them cause dilation. Over on the far right-hand side of the bottom line are the thromboxanes, which are types of prostaglandins that cause platelet activity, and they stimulate platelets to contract. Prostaglandin F2 is they stimulate, very strong stimulator of smooth muscle contraction, which is important during childbirth. So again, prostaglandins are not the same. They're a family of compounds, and they do different. So that, in the preceding slide, we talked about how prostaglandins are made. Now we're back to what do the NSAIDs do. The NSAIDs are very powerful, very potent inhibitors of the cyclooxygenase enzyme. If they find this enzyme in the cell, they bind to it and they shut it down. So the cell can't make the first prostaglandin. If it can't do that, it can't really make any prostaglandins. And this explains how NSAIDs have so many different effects. Some prostaglandins increase pain. We've eliminated the ability of the cell to produce those. Some of them affect platelets and blood coagulation. We've eliminated those. Others caused muscle cramping, eliminated those. And this was a huge breakthrough. The people who discovered this back in the early 1970s got the Nobel Prize for this discovery. Again, the discovery that NSAIDs are cyclooxygenase inhibitors. And by understanding this, we can study this enzyme and then develop other NSAIDs that can affect that enzyme. So again, a huge, huge breakthrough, and it really led to...
Press pause and read this slide before proceeding to the next one for the answer.
So, NSAIDs inhibit this enzyme, the cyclooxygenase, or what we're simply from now on going to call the COX or COX enzyme. And by doing so, they decrease prostaglandin biosynthesis. The next step in this process was to discover that the COX enzyme exists in at least two primary subtypes. These are isoenzymes of each other. They're like cousins. And the major subtypes are the COX-1 and the COX-2. And they have very different functions or dissimilar functions depending on which one is present in the cell. So here's our COX-1 subtype. The COX-1 enzyme is found all the time. It's a normal constituent in certain cells. It's there, again, on a day-to-day basis to help that cell function. And in these cells, the COX-1 subtype synthesizes what I call the good prostaglandins that help protect the cell and maintain its normal day-to-day function. Some key places where you're going to find the COX-1 are in the stomach, where the stomach COX-1 produces prostaglandins that help protect the stomach lining from hydrochloric acid. COX-1 in the kidneys produces prostaglandins that maintain renal blood flow, maintain glomerular filtration rate. And COX-1 in the platelets enables the platelets to function normally and become sticky and coagulate when it's time to do so. The COX-2 form is not always present. It's produced or induced when the cell is injured. And it's the one that synthesizes the prostaglandins that we're more concerned with, that help mediate pain, inflammation, and do all the other things we've attributed to a damaged cell. Possibly promote fever, possibly promote abnormal coagulation or even abnormal cell division that could become precancerous. If you, for instance, go into somebody with rheumatoid arthritis and you aspirate the joint, say a knee joint, you'll find it's loaded with COX-2 enzyme. And other pathologies that deal with these kinds of injuries will also use or synthesize the COX-2 enzyme to inhibit, to produce these, I don't want to say harmful prostaglandins, but the prostaglandins that are associated with. So by knowing that we have these two forms of COX enzyme, COX-1 and COX-2, it was obvious that it would be preferential to inhibit the COX-2 enzyme and not inhibit the COX-1. This led to the development of the COX-2 selective drugs. The idea being that we want to inhibit the synthesis of the prostaglandins that promote pain and inflammation, which are of course produced by the COX-2. At the same time, not inhibit or spare the production of the beneficial prostaglandins, tissues like the stomach, the kidneys, the platelets. And if this is possible, we may see a situation where the patient will have less pain, less inflammation, with less of the really common side effects of the traditional NSAIDs, especially stomach irritation or gastritis. And in some patients, this is all true. Patients respond really well to these COX-2 selective drugs, and they do just what they say they're going to do. The first drug on the market to do this was celecoxib, Celebrex, and it's now the only remaining COX-2 selective drug. Others that were produced or were in production or in development were removed from the market, as we'll see in a minute, because they had some pretty severe side effects. But this drug may, in some of our patients, do, as I said, exactly what it's supposed to do. Less pain, less inflammation with less problems and less gastritis. Other patients, however, not really so much benefit. They may not have bad side effects, but the drug just doesn't work as well as maybe a traditional NSAID. The other extreme is true in again, a different set of patients. We will find patients where this drug actually causes some pretty severe side effects, including severe gastric irritation, even though it's not supposed to. This is all due to the fact that our patients are very different from one another, and it's probably genetic factors. So again, we have one cohort where the drug does just what it's supposed to do. Other cohort where, well, somewhere in the middle, it doesn't work badly, it just doesn't work as well as a more traditional drug. And in other patients, it's contraindicated. It should not be used because it causes very severe side effects, even hemorrhage, gastric hemorrhage. The real limitation, however, is that the concern about the COX-2 selective drugs is that so soon after the COX-2 drugs emerged, it started to become apparent that there was a chance they would cause cardiovascular problems. And we're talking specifically about infarction. Myocardial infarction leads to heart attack, or a carotid artery infarction leading to ischemic stroke. This was the reason the next two drugs to reach the market, Vioxx and after Celebrex, were Vioxx and Bextra. They were recalled off the market because of this increased risk. And the history of this is pretty interesting. Vioxx was actually withdrawn by the manufacturer because they realized, they said, when they were testing the drug, for its possible benefits in colorectal cancer, that's when they realized that there might be a risk of heart attack and stroke, and they voluntarily removed the drug. That's very rarely done. Bextra, the FDA required that the company remove it because there was a clear risk of heart attack and stroke and an increased risk of skin reactions, severe toxic necrosis of the skin was linked to this drug, so it was required by the FDA that it be removed. So Celebrex is the only drug of this type that remains on the market. But the story doesn't end there. Some NSAIDs, traditional NSAIDs, so-called, may also be more selective for COX-2. And if so, they will also have a similar property of increasing the risk of infarction. So here are three examples of drugs that are not specifically called COX-2 inhibitors. They don't have that COXIB ending on the generic name that you saw with celecoxib, but they clearly have a more tendency to be selective for COX-2 compared to COX-1. A lot of NSAIDs are fairly equal. Some NSAIDs even have more of a preference for COX-1 inhibition, but these guys here are at least 5 to maybe even as much as 50 times more selective for COX-2 than COX-1, depending on the dose, the type of patient, and so forth. So this is an awareness that even though they're classified as traditional NSAIDs, they may function more like a COX-2 inhibitor and carry the same type of cardio. The question then arises, why does COX-2 selective inhibition promote infarction? What we're thinking is that normally there's a balance between the prostaglandins that promote dilation, which come primarily from the COX-2 enzyme, and the prostaglandins that promote constriction, which come primarily from the COX-1 form. And if both enzymes are present, this constriction dilation balance remains okay. But if we selectively inhibit the COX-2 form, we have a predominance or a lack of the prostaglandins that promote vasodilation, and therefore the prostaglandins that promote constriction and increase platelet activity, the COX-1 prostaglandins, start to dominate. Is this true in all patients? No, probably not. Again, it's probably a genetic-based predisposition and simply a sensitivity. I think in some patients, the COX-1 and the COX-2 forms of the enzymes are not really that different, again, in certain patients. But if there's a distinct difference in these enzymes, they're proteins, so they can be either quite similar or quite different depending on the patient. But if the person has a really distinct difference in their COX-2 versus COX-1 form, and we can preferentially inhibit the COX-2 form, you get into this kind of problem. Other things are involved too. Cardiovascular risk factors may certainly play a role. Increased cholesterol, those kinds of things. But it's this idea or this awareness now that selectively inhibiting COX-2 may be really harmful. So we've been talking about NSAIDs. We saw the progression from development of simple aspirin to more complicated but traditional NSAIDs to the most recent step, the COX-2 drugs. We haven't yet talked about this very specific medication called acetaminophen. Acetaminophen does have anti-pain or analgesic effects, often very good, and it decreases fever. It has antipyretic effects. It's typically the go-to drug for children and teenagers with fever. We know, of course, you should not give aspirin to a child or teenager with a fever because there is this association of aspirin with a rare but serious neurological condition called Reye's syndrome. It doesn't occur with acetaminophen. It doesn't occur with other NSAIDs like ibuprofen, but we don't want to give aspirin to children to treat a fever. So it was really, again, a go-to drug for pain and fever in a lot of people. It doesn't upset the stomach, and this is one of the big marketing tools of this drug. You can take it to treat pain, and it does not have a tendency to upset the stomach. All true. What's less well known is that this drug does not really decrease inflammation or affect blood coagulation. And it's the anti-inflammatory effects that are often important for our patients. If a patient does have pain and inflammation, this drug is only giving them half the benefit. Again, not as well known. Now, why is acetaminophen different from the NSAIDs? It's not really that clear. It seems to be that acetaminophen only affects prostaglandin production in the central nervous system, brain and the cord. Let's see if that makes sense. We feel pain in our brain, in our somatosensory cortex. So, by controlling prostaglandins in that part of the brain, we have the analgesic effects. We control body temperature, fever, in the hypothalamus. Again, by affecting those prostaglandins, we get the antipyretic effects. But gastric irritation, inflammation, say in a peripheral joint or peripheral tissue, and blood coagulation, these are all peripheral events. They take place outside the central nervous system. So that's our explanation of why acetaminophen is not an NSAID, why it has this differential effect on pain versus inflammation and so forth. The other thing that's really different or really important about acetaminophen is that in high doses it can be very toxic to the liver. And this again is not well known, not well appreciated by our patients and our clients. So here's how acetaminophen causes toxicity to the liver. In the liver, acetaminophen is metabolized by first transforming it enzymatically into a byproduct called N-acetyl P-benzoquinonamine. Almost immediately, this product is coupled to an amino acid type substance called glutathione, shown here as GSH. By coupling these two products together, you form mercaptoric acid, which is sent to the urine and excreted by the kidneys. In a healthy liver, at a normal dose of acetaminophen, this process occurs very quickly, and there's no problem. We can get rid of the acetaminophen byproducts quickly. But if there's liver damage or a person's had some chronic liver disease, or the dose is too high, or both, this intermediate product, N-acetyl P-benzoquinonamine, starts to build up. And this is the toxic substance. It can affect liver enzymes, and it can actually cause necrosis of these liver proteins and enzymes. If severe enough, it can lead to acute liver failure and death. Now, key question is, well, what's a high dose? When does a dose become problematic or even fatal? Healthy liver, 15 grams can be fatal, although much higher doses people have survived. So it really relates to, again, the patient and how much liver function they have. The other extreme would be a patient that maybe already has some severe liver disease from chronic alcohol cirrhosis or hepatitis or other types of liver dysfunction. Even a regular dose, an over-the-counter dose of acetaminophen can be fatal. So it's this balance between how much drug and how healthy is the liver that really determines this level of toxicity. But acetaminophen toxicity is extremely common. One of the most common reasons for drug admissions to emergency rooms is good old-fashioned acetaminophen, which is really kind of shocking when you think about it. With all the drugs that are possible, acetaminophen is one of the most common reasons for drug admission admission to emergency rooms. Our patients are simply not aware of that, and they should be. It's a very good drug, but we do have this very important should be. Now, acetaminophen is also combined with opioids. We talked about the opioids in the first part of this pain inflammation section. We see this very commonly done, especially after surgeries. Tramadol, an opioid, is combined with acetaminophen, and it's usually a given amount of the opioid with 325 milligrams of acetaminophen, and you'll see it listed by a trade name like Ultracet. Another example is something like hydrocodone, which is the opioid part of it, Lortab, Lorcet, so forth, oxycodone. These are just a few examples. But if you see that set, like Endocet or Tab or one of these types of endings, you're usually talking about the opioid combined with an acetaminophen. The obvious goal is to reduce the need for the opioid by balancing it out with a non-opioid, in this case acetaminophen. And my only other point about this is that some patients do really well on these. And if they're getting good pain control, we're happy. But if they're not, it's usually due to one reason or another. And the first reason is there's not enough opioid in the combination. We'll try to really reduce the level of the opioid needed, and sometimes it's a little too much reduction, and there's just not enough opioid to do its job. The other reason you may see it is some people just don't get good pain control from the acetaminophen. So now you're getting a low dose of the opioid with no benefit from the non-opioid. My point again, if you are seeing patients with one of these products or taking one of these products that is not getting good pain control, you have to document it. And maybe it's solvable by just tweaking up the dosage of the opioid a little bit, or maybe tweaking up a lot and simply removing the acetaminophen because that patient, for whatever reason.
Press pause and read this slide before proceeding to the next one for the answer.
So to summarize our major concerns about the non-opioid analgesics, gastric irritation is certainly the most common and the most famous problem of the NSAIDs. The good news here is it's usually self-limiting in the sense that if a person gets a really upset stomach, they often go back to their doctor and say, I can't take this drug. Do you have something else I could try? So it is common, it is serious, but again, usually pretty obvious, pretty self-limiting. A more serious problem, because it's not as obvious, is the chance for liver, hepatic damage, or kidney, renal toxicity, especially if these organs have already been damaged to some extent. Like I was talking about with acetaminophen, how much damage occurs is really variable depending on other factors like previous damage to the organ, the dosage of the drug, the patient's age, and so forth. If patients are concerned, we can certainly have their liver function and their kidney function checked. If they're going to be on an NSAID for an extended period of time, this is not a bad idea. Periodically monitor liver and kidney function. Another concern is the cardiovascular risk. NSAIDs also increase blood pressure. They increase blood pressure on average about 2 points in a non-hypertensive person, but may increase it 4 points or more if a person has high blood pressure. And like I said, most of our clients, most of our patients are not aware of this fact. And we saw that some of these, especially the more COX-2 selective drugs, whether it's a traditional COX-2 selective drug or an NSAID that has more of a preference for COX-2, can dramatically increase the risk of infarction. So again, some awareness on our patient's part is really important. And if there is concern, refer them back to their doctor to talk about it. The other thing that's really important for us is that it was discovered that NSAIDs may impair bone and cartilage healing. And I left a question mark there because there's still a lot of information that we just not sure of yet. It's clear now that traditional NSAIDs should probably not be used after acute bone injuries like fractures or bone grafts, something like a spinal fusion. It seems prostaglandins are important in starting the bone healing process. NSAIDs inhibit prostaglandins, so we don't get that initial step or we lack that initial step in the bone healing process. Cartilage healing is less clear. It looks like some NSAIDs may, in fact, impair cartilage reproduction, cartilage healing, which is really important considering that a lot of patients are taking NSAIDs for conditions that are notorious for cartilage damage, like osteoarthritis. Other NSAIDs, including the COX-2 drugs, may actually increase cartilage healing. So that's why I left a question mark there, because there's still a lot we have to learn. Another adverse effect, and this refers specifically to aspirin overdose. Patients may take some aspirin, forget they took it, take some more an hour later. Now they're starting to get a headache, so they take some more an hour after that. And if they start to have a hearing loss, buzzing, ringing in the ears, or tinnitus, they get confused, it could be aspirin intoxication. It's usually reversible, but we certainly want to catch it early before this possibly causes more permanent or even severe or permanent damage. And finally, we can tell our patients that these drugs are different from one another, especially the difference between NSAIDs and acetaminophen. Most of our patients and clients do not. They're not really aware of that, and they assume that acetaminophen is the same thing as an NSAID, and clearly it's not. We cannot tell the patient what to take. We can't say, well, you should stop taking Tylenol, you should start taking Advil. That's beyond our practice set. But we can be a healthcare educator and certainly tell them the difference between these two types of medications, refer them back to the physician if they have questions or think that maybe they should be taking a more traditional NSAID compared to an acetaminophen product. And that's a key difference, but it is an important part of it. So we're now going to talk about inflammation. We're going to leave the pain area specifically to talk about inflammatory conditions. And our first key player in this role is back to the NSAIDs, and this is how they got their name, non-steroidal anti-inflammatory drugs. So we've met these guys already. We're going to say a few final words about them. Then we're going to talk about this other group of anti-inflammatory drugs called the anti-inflammatory steroids, or for lack of a better term, I'll call them glucocorticoids, because they have a dramatic effect on glucose metabolism as well as produce really good anti-inflammatory responses. But let's first finish up with the NSAIDs. So we talked about the use of NSAIDs in pain. Now we want to talk about it specifically in inflammation. They work the same way they worked when we talked about them in pain, in treating pain. Certain prostaglandins are inflammatory mediators or inflammatory messengers. If we inhibit them, we decrease the promotion of the inflammation. The only thing to add, or one of the only things to add, is we may see a slightly higher dose used sometimes to treat inflammation than to treat simply pain. It's not true all the time. It's not true for all NSAIDs, but you may see different doses, a specific dose of, say, 1,200 milligrams for the drug to treat pain, and maybe 1,500 milligrams to treat inflammation, just as an example. More importantly, we're aware now that when a person starts on an NSAID to treat acute inflammation, they should probably take the whole dose. It's almost like an antibiotic, and we'll see the same scenario or the same strategy when we talk about antibiotic medications. Take the whole medication because you're trying to control the whole infection. Inflammation's different, but the same idea holds true. If you've got an inflammatory response, it's better to really try to come at it and get rid of the entire response right away. I always think of inflammation as like a smoldering campfire, and you have a big bucket of water, and you can dump the whole bucket on the fire and try to put it out right away. And that's what we're talking about. As opposed to, say, put a little water on the fire, it goes down quite a lot, it's almost out, you walk away, but it's not out, so it flares up. You come back, you dump a little more water on the fire, it goes away, and you eventually never really solve the problem and finally run out of drug before you've completely solved this or resolved the inflammatory response. Patients will start on an NSAID for an acute inflammation, and they'll feel better after a few doses, or after 2 or 3 days, because of the analgesic effects. But that inflammation is not completely resolved. So some of the newer docs, some of the docs now are kind of enforcing that with the patients. Again, I'm not going to tell my patient whether they should or shouldn't take their medication. I'm going to make sure they understand the idea here. And if the doctor has said to them, take the whole medication, don't stop halfway. I'm giving you a 7-day supply or a 10-day supply. That's the idea, and that's the strategy. So again, there's more of an awareness. But let's now talk about this other group of anti-inflammatory drugs called the glucocorticoids. As I said, we should call these guys glucocorticoids to differentiate them from other types of steroids. If we say steroid to our patient, they invariably think of anabolic steroids, which are very different. All steroids have a similar origin, but they have very different pharmacological, physiological effects. So if you want, you can call these simply anti-inflammatory steroids, and that's probably not a bad idea with some patients. But the chemical name often is glucocorticoid because, as I said, they do have a dramatic effect on glucose metabolism. So we're seeing them now for their powerful anti-inflammatory effects. And they also suppress the immune system, which can be very beneficial in certain autoimmune diseases or really beneficial in preventing organ rejection. We're getting better and better immunosuppressive agents. So the reliance on these drugs for that aspect has fallen back somewhat, but still they're a mainstay in certain types of suppressing the immune system in certain conditions, especially solid organ transplants. But we're going to focus now on their inflammatory job, their role. So when they're used for inflammation, they have many uses and indications. What I mean by that is inflammation is not a disease. It's a symptom, a sequela to another condition. And that's important because these drugs are often very good at solving or resolving the inflammation, but they may not necessarily resolve the source of the inflammation. Give a simple example. If a patient has lateral epicondylitis, literally tennis elbow, we can treat that, maybe use some glucocorticoid iontophoresis using dexamethasone, and it probably is going to work pretty well. It's a very superficial tendon. It's easy to get at. We can do other things like transverse friction massage. But still, if we don't solve the source, why did that person get that lateral epicondylitis in the first place? Is it from an overuse injury? Is it from poor mechanics when they are playing tennis? Is it because their wrist extensors are weak? We have to resolve that problem. Otherwise, when we stop giving the drug, the original problem will come back. So that's an important aspect of glucocorticoids that we always have to consider. Try to solve the source of the inflammation at the same time. Now, I mentioned a second ago that these are steroids. And steroid biosynthesis, we have three major families of steroids, and that's what you're seeing here. We're talking about the family that's on the left side of this diagram, the anti-inflammatory steroids. Cortisol, for instance, is the one we produce in our own body. In the middle, you see the family of the mineralocorticoids. Primary one in humans is aldosterone, and these cause salt and water retention. On the far right is the family that, for lack of a better term, we'll call the sex hormones. That contains testosterone, estrogen, progesterone. And we'll talk about them when we talk about endocrines. The only reason I show this is that there is a lot of structural similarity between these three families. So when we give an anti-inflammatory steroid, we may get side effects that are related to the middle family, the aldosterone drugs, which retain salt and water. Same thing with some of the sex hormones. So even though each of the three families is very different from each other in their primary effects, we often have side effects that cross over between families. We'll see that whenever a steroid. And there's a lot of these. You recognize, I'm sure, some of these names like cortisone or hydrocortisone. They've been around for a long time. They're very available, very affordable. And they tend to have that own suffix. So cortisone, as I said, dexamethasone I mentioned, very potent drug. We tend to use this one a lot with iontophoresis. And the prednisolone, and methylprednisolone drugs, again, very common. So no shortage of these drugs. So how do they work? We have to consider the anti-inflammatory effects because, as I said, these are powerful drugs, and they are. If you get enough drug to the site of inflammation, it is going to work. It is going to have an anti-inflammatory effect. They start by acting on the cells that, again, initiate the inflammatory response. The macrophages, the leukocytes that are responsible for engulfing invading material, or what they think is invading material, presenting that to the T lymphocytes. So they go right to the start by going to these cells. And the way any steroid works is the drug goes right into the cell. It does not bind to a receptor on the surface of the cell. These drugs are made from cholesterol. So they march right through the cell membrane. They bind to a kind of a guide receptor. I always think of it as sort of a guide once it gets in the cell. And the receptor guides the drug to the nucleus, where the drug binds to specific genes that control inflammation. And this is why steroids are so powerful. They all do this. They go to specific genes and they tell the cell what to do. In this case, the anti-inflammatory steroid is binding to specific genes and decreasing the production of inflammatory proteins, cytokines, enzymes, and so forth, and actually increasing the production, expression of a few anti-inflammatory components. And that's, as I said, that's why these drugs are so effective. They don't just bind to the surface of the cell. They don't just encourage some other mediator within the cell. They go right to the genome of the cell and control production of messenger RNA. And that's what this diagram is showing. On the left side, the H, the blue molecules, H stands for hormone, marches right through the cell membrane, binds to that green cytoplasmic receptor. The drug and receptor march to the nucleus and bind to specific genes called glucocorticoid receptive elements. So it's not a random binding. They're going to very specific places, and they really act as what we call now a transcription factor. They change the transcription of messenger RNA to, as you saw a second ago, to produce less inflammatory components or mediators and produce more anti-inflammatory. So you get a sense of how direct these drugs work, or why these drugs are so good at what they do. Go right to. Now, we haven't talked a lot about administration, but we should, because I keep saying we want to get enough of the drug to the site of inflammation. And of course, you can give these drugs orally, and then they will go systemically, meaning throughout the entire body, and eventually reach the site of inflammation. If that's true, we try to find a regular or maintenance dose that is minimal, because as we're going to see in a minute, these drugs do have some pretty serious side effects. But if they are affecting inflammation, say in a knee joint, they're also going to all other cells in the body. There's no way to control that. We can do this a little differently with something called a dose pack. You may have seen this. The idea here is a person will take, in this case, 6 pills the first day. We're trying to take that bucket of water and really dump it on the fire. The second day, they'll take 5 pills. And they're spaced out over several hours throughout the day. They're not all taken at once. But the idea is to use a really large dose right away. Then, next day, start to taper it off somewhat. Next day, a little less, 4 pills. Next day, 3 pills, and so forth. So as you're dumping this bucket of water on the fire, you're also starting to taper it off to allow the body to recover from that high dose. So that's what the dose packs do. They try to to get the problem under control quickly, while also allowing the body to recover before you completely withdraw the drug. And sometimes they're very effective at this, and maybe really good at, again, getting that problem under control. Then we have these other strategies. And of course, injection is important. The idea here is often to inject the drug into a specific joint because that joint is really inflamed. And it could be a shoulder, it could be a knee, it could be a hip. The good news here is you're not sending the drug to all other tissues in the body. You're putting the drug and concentrating it right where you need it. And it's not a bad thing. I keep come back to the initial point of you want to concentrate that drug or keep that drug or get that drug right to the place where in the body that needs it the most. But this gets a lot of bad publicity because, of course, it can cause joint damage if you overdo it. But if it's done right and if it's done judiciously and carefully and not overdone, it's a very effective way to treat that joint. So we often see limitations placed on how much you can do. And 4 per year is probably being really generous. A lot of physicians won't do more than 3 per year per 12-month period. Sometimes they will have a limit to how much you can inject into a given joint for the lifetime of that joint. But it comes back to the initial point that it's not a bad way to treat this problem And if it works, we may be able to get by with 2, maybe 3 injections and really get that under control, and then maintain the joint structure, maintain and function, and decrease inflammation, or maintain the decrease in inflammation using our techniques in physical therapy. So this is it's a possibly beneficial thing, as long as you don't overdo it. And finally, there's other ways to give these drugs. They're inhaled a lot of times for conditions like asthma, and we'll talk about that when we talk about the pulmonary drugs. Again, a very valuable way to treat the problem. Apply the drug directly to the respiratory tract. Topical for skin rashes or skin inflammation, nose drops, eye drops, ear drops, all following the same idea of put the drug where you need it. Don't send it to every place in the body, but keep it concentrated at the site of the inflammation.
Press pause and read this slide before proceeding to the next one for the answer.
Which brings us to our major concerns. The big concern for us as clinicians, not necessarily the most life-threatening, but the biggest concern is that these compounds, anti-inflammatory steroids, break down collagen. And they're going to have a breakdown or catabolic effect on virtually all supporting tissues, like bone, muscles, ligament, tendon, and skin. What they're in fact doing is they're breaking down collagen in these tissues to generate amino acids to send to the liver to turn into glucose. That's why they're often called glucocorticoids, because they think their job is to make sure you've got a lot of glucose ready in your body. I mean, you can't just make glucose out of thin air. You have to make it from something. So again, you're breaking down protein tissues here, bone, muscle, and so forth, to generate components that could be turned into glucose, and the liver can do that. If you only have a little bit of drug, only use it for a short period of time, this is not going to be a big problem. But of course, we have patients on these drugs for extended periods of time at fairly large doses, and this catabolic effect will become pretty obvious. Good news. We can prevent some of this. If we can put this person on a strengthening program, a weight-bearing exercise program, and so forth, we can prevent some of this breakdown. We know that by strengthening the tissue, by strengthening muscle, by having the person, by protecting the skin, and so forth, we can prevent some of this breakdown effect. The trick is really protecting the tissue before there's been a lot of damage from the drug. In a perfect world, we'd be able to start these interventions well before the drug is administered. But of course, we're going to see many patients that already have a lot of bone breakdown, a lot of bone loss, possibly from osteoporosis. They maybe have some ligament, tendon, muscle damage already. But still, if we can be careful and put that person on any kind of a resistive or weight-bearing program, we can definitely stabilize or maybe even reverse some of this catabolic effect. And that takes a lot of skill, but it is a very beneficial thing we can do. That's just the tip of the iceberg. These drugs have many other side effects. And oftentimes they're related to metabolic dysfunctions. For instance, they do cause salt and water retention because they're like their cousin, aldosterone. They suppress the immune system, so they increase the chance of infection. They will take away protective prostaglandins from the stomach, which leads to gastric ulcers. You get the sense that they really affect glucose metabolism, and it can cause glucose intolerance or even kick a person over into full-blown diabetes if they are borderline. They cause glaucoma because they reduce the vitreous drainage from the eye. So these are all metabolic type issues. But the big concern is the last thing, and it's called adrenal suppression or adrenal cortical suppression. By giving large amounts of these hormones as a drug, you suppress the adrenal gland's ability to produce our own endogenous glucocorticoid, which is cortisol. It's a negative feedback effect. The large dose of the drug inhibits both the hypothalamic, pituitary, and even the gland itself. That's okay while you're giving the drug, because the drug substitutes for our own production. But if you suddenly take the drug away, it takes the adrenal gland about 4 or 5 days minimum to come back into production. And that's dangerous because you got about a 4 or 5, maybe even a week gap. So let's talk about adrenal cortical shock. What does it look like? It's not pretty. It is extensive vascular collapse where virtually all the blood vessels in the body have become wide open and tissues become engorged. You can see the purple marks where blood is flooding into subcutaneous tissues. Blood pressure is plummeting. And organs, you don't see it on this slide, but organs are also becoming engorged in blood, which leads to severe organ damage to the liver, the kidneys, the spleen, and so forth. And this happens when glucocorticoids are suddenly discontinued after extended use, a month or more. So here's a possible scenario. Your patient's been on these drugs now for a couple of weeks, and the patient will say, I'm feeling a lot better. My knees don't hurt as much. I feel good. But I'm gaining a lot of weight, my skin is getting all broken out, and I'm getting rashes, I'm losing muscle mass, my arms and legs are getting really thin, and I'm going to stop taking the drug. Absolutely not. Make sure they understand that maybe it is time to go off the drug, but you have to do this carefully under close medical supervision. So encourage them to contact their doctor and talk about possibly going off the drug. But one more time, it has to be done under very careful supervision. So that concludes our discussion of pain and inflammation. And again, I hope this information is helpful. And we see these drugs so often.